Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is September 22nd, 2025. This video is on a Lancet article titled Immediate versus Staged Complete Revascularization During Index Admission in Patients with STEMI and Multivessel Disease. The option STEMI trial, a multi-center, non-inferiority, open-label randomized trial. There was an accompanying commentary published on the same day titled Immediate or Staged Complete Revascularization in Patients with STEMI. Multivessel coronary artery disease affects about 50% of the STEMI patients. Complete revascularization is now standard, but the timing remains debated. This study was option STEMI was a multi-center randomized open-label non-inferiority trial in 14 hospitals in South Korea. The study cohort comprised of 994 STEMI patients, median age 66 years, 79% were men, 33% had acute heart failure, Killip II or III. The intervention was PCI to the culprit lesion, plus immediate versus staged PCI for non-culprit lesions within the index admission. Statistics hazard ratio for non-inferiority margin of equal to 1.42, powered at 80%, primary endpoint a composite of death, myocardial infarction or unplanned revascularization at 1 year. What did they find? The primary endpoint was 13% in the immediate PCI group versus 11% in the staged group, hazard ratio 1.24, p-value 0.24, non-inferiority not met. Adverse events, cardiogenic shock 4% in the immediate PCI group versus 2% in the staged PCI group. Death from any cause 7% in the immediate PCI group versus 5% in the staged PCI group. Stroke, myocardial infarction and bleeding rates were similar. The limitation of the study was open label, 80% from one center, high crossover, low female inclusion, 21%, and there were FFR limitations. Key takeaways: immediate revascularization during index admission is not non-inferior to staged PCI. Clinical implication: avoid immediate revascularization in patients with Killip class equal to or greater than 2 heart failure. Safe for low risk, stable STEMI cases. The accompanying commentary reviewed option STEMI and questions the wisdom of immediate complete revascularization in STEMI with multivessel disease. All-cause mortality was numerically higher with immediate PCI across 4 other trials. Death and repeat PCI trended higher in the immediate PCI group. Limitations: inclusion of procedural MI may bias outcomes. FFR use for non-culprit lesions with 50 to 69% stenosis is debatable in acute settings. Key insight: evidence tilts in favor of culprit-only PCI during primary intervention, with staged revascularization better reserved for later. Future direction: need more trials, timing of staged PCI in hospital versus post-discharge, since this remains unresolved and warrants further trials. The commentary refers to 4 recent trials that examine the timing of complete revascularization in patients with STEMI, highlighting a consistent pattern of numerically higher all-cause mortality with immediate complete revascularization. And these are the BioVasc trial, published in Lancet 2023, Multi-Stars AMI trial, published in NEJM 2023, and a study published in Eurointervention 2024 by Scarparo et al., including this trial, the option STEMI trial. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom.